Hi friend, this is Dr. Apurv Mehra and let's talk about the question that appeared in Neet PG 2021. This was absolutely standard paper, repeated topics, expected guidelines. If I look at orthopedics, out of 200 we had 8 questions. The first question is a classical learning of orthopedics. This is a statement that you should remember if you are sleeping, कोई आपको उठाता है और बोलता है there's a tumor of the lower end of radius. You have to speak it as a giant cell tumor. If you look at Robbins, the classical line is giant cell tumor can go and involve the cartilage rarely. This is subchondral. So I used to remember it like this. The giant will go till the joint. So joint. Normally tumors, they respect the cartilage, they respect the joint. Infections, they eat both. But the only tumor that goes till the joint is the giant. So you will have a lesion which is just beneath the joint line, and classically they say it's epiphyseal, but because it is seen after skeletal maturity, so that distinction of being epiphyseal is not followed. So it's epiphysio-metaphyseal. So when you look at a tumor, you look at the age and the part. Part is always more important than the age. So after maturity, they will classically give you age group of 20 to 40 years. Part is epiphysio-metaphyseal. If you look at this image, you hardly see the bone, because giant cell tumor is a tumor which loves to eat the bone. Slowly will finish it up, expand it, and one is a benign tumor, one is a malignant tumor, and the third category is a locally aggressive tumor. So this is a tumor along with adamantinoma, which is a locally aggressive tumor, and both on X-rays will have soap bubble appearance. Adamantinoma is classically seen in the tibia, and GCT, if they ask you lower end of radius, you think of GCT. But if they ask you GCT, you think of lower end femur. Now this is confusing. It's like a love triangle. Lower end radius को GCT पसंद है. So the tumor that most commonly affects the lower end radius is GCT. But GCT को lower end femur पसंद है. Means the most common location of a giant cell tumor is lower end of femur. And for your entrance exams, remember 3 things which are there in lower end femur. This is something which you should not falter on. Number 1, osteomyelitis. Number 2, giant cell tumor. Number 3, osteosarcoma. All 3 are exam questions. So let's look at this question. 20-year-old, male. Bone tumors are usually more common in males, but there are 2 tumors which are more common in females. G for girls, G for GCT. F for females, F for fibrous dysplasia. But here they have given a history of male. That's okay. Gradual swelling. Gradual means it's not rapidly growing. So we are not dealing with something which is malignant. Gradual also means it's progressive, unlike benign, which can be sometimes latent. And around the wrist. And the time period is given 3 months. X-ray is given below. This X-ray is number 1 asked image in entrance exams in last 1 decade in the country. So these are the questions you must never miss. Looking at options, E-wings, it's a diaphyseal lesion. Now here also there's a love triangle. First decade को Ewing's पसंद है, but Ewing's को second decade पसंद है. So the most common tumor that occurs, bone tumor that occurs in the first decade is Ewing's, but the peak incidence of Ewing's is seen in second decade. But is it the commonest tumor of second decade? No, because at that age there is osteosarcoma, which is much more common. Osteosarcoma is a metaphyseal lesion. So friends, if the question is 15-year-old male has a malignant tumor at the end of femur, think about osteosarcoma, because ends are epi or meta. 15-year-old male, malignant tumor, middle of femur, think about Ewing's, because middle is diaphyseal. Remember, if you look at the latest edition of Campbell's, it mentions Ewing's originates from the marrow. In fact, it originates from the marrow of the metaphysis, according to the latest hypothesis, but it localizes into the diaphysis. So is it a metaphyseal lesion or diaphysis? It's always the destination that decides the location, because you will never see it in the marrow, because that's a stage at which cells are multiplying. And these classifications are radiological or clinical. So this is a diaphyseal lesion. Osteoid osteoma is a diaphyseal lesion. Now there's a word of caution. The literature in today's world is divided. Is it dia or meta? But for entrance exam, you still go with dia, and you will find a line here that patient has night pain relieved on taking salicylates or aspirin. Why? Because this is rich in PGE2, which is responsible for hyperalgesia. And the first option, the answer here is GCT. Question number 2. I always tell you this. Young females, bilateral hand pain, morning stiffness, think of RA, rheumatoid arthritis. So if I look at two criteria of RA, one is 1987, second is 2010. 1987, at the end you have 7. So total criteria are 7. 2010, at the end you have 10. So total number of marks are 10. So if I look at 1987 criteria, it says 4 out of 7 is RA. Number 1 is morning stiffness for more than 1 hour. Number 2, 3 out of 14 joints involved. The joints are PIP, MCP, wrist, elbow, so these are 4 joints, knee, ankle and metatarsalophalangeal. In the lower limb, 3 joints. 4 plus 3, 7, both the sides 14. If any 3 areas are involved, it's one of the criteria. Third, bilateral symmetrical. Fourth, hand involvement. Fifth, rheumatoid nodule positive. This is diagnostic or pathognomic point. Sixth, RA factor positive. And seventh, X-ray changes. So the first 5 are clinical points. You need 4. Can you diagnose RA without a blood test? Yes. So bilateral hand pain means symmetrical hand involvement. Bilateral, assume it to have more than 3 joints. Morning stiffness, 4 out of 14 present. You don't need anything. Female is not a criteria. Age is not a criteria. But they give you a history like this, except in Neet 2019, where they give you in the history 65-year-old female. 2010 criteria. More than 10 joints involved, 5 points. very high rheumatoid factor and TCCP, 3 points, high ESR and CRP, 1 point, and more than 6 weeks duration, 1 point, total 10. More than 6 or more than 6 is equal to RA. So this is the criteria for RA. If I look at ankylosing spondylitis, classical, young man, low backache, reduced lumbar movements, reduced chest expansion. This is classical of ankylosing spondylitis. If I look at the modified New York criteria, they say essential criteria is radiographic sacroiliitis. They don't mention unilateral bilateral in the criteria. In the latest edition of Harrison, they say that sacroiliitis should be proven radiologically on MRI. Plus one of the 3 supporting criteria, inflammatory backache, reduced chest expansion, decreased lumbar movements, which they score by Chaubert's or modified Chaubert test. So essential plus 1 supporting is ankylosing spondylitis. But classical history, low backache, reduced chest expansion, decreased lumbar movements is ankylosing spondylitis. Let's look at this question. 20-year-old man, low backache, morning stiffness, last 2 years with heel pain. Let's look at the options we have. Disc prolapse. It doesn't look like a possibility because here you should have radicular pain and they usually don't have morning stiffness. Same with back pains, the mechanical back pains. Mechanical back pains are more after heavy work. TB spine, rather than morning stiffness, will have night pain, night cries. So if you look at the questions here, if you look at the options here, ankylosing spondylitis is a classical answer. And look in the same paper. If your X-ray looks more white in the spine, it's going to be AS, ankylosing spondylitis. What you see here, you see bilateral sacroiliac joints are almost fused. Your entire spine is fused, and in the center of the spine, the interspinous and supraspinous ligaments are ossified. They are calcified. And if you look at the dagger is a long, thin knife, as thin that you can stick it with a band and put it under your palm. So in the older times, when they were kings fighting, they will always put a dagger in their left hand. They will throw a knife or a sword in the right, and just to deceive their enemy, they will drop it. And then suddenly, as the enemy will lose the focus, will take out the dagger, thin dagger, and stab in the neck. So that's the dagger, and this is the dagger, thin dagger, right in the center. And if you see this ossification, this is ankylosing spondylitis, bamboo spine, dagger sign, and if you look, the ossification occurring around the facet joints as well, then it's look like tram track sign. The entire track has been laid down. It's all white everywhere. So this is called as a tram track sign, ankylosing spondylitis again. And if they go to metabolic disorders, they won't leave osteoporosis, rickets, or scurvy. So there's been a question in every exam on osteoporosis. Look at this question, post-menopausal. The moment they talk about post-menopausal, they are indicating the bones are weak. With history of colles fracture, definition of colles has been described for extra-articular osteoporotic fracture of the lower end radius. By definition, it was for osteoporotic. over time, because the classification, the definition of colles was given in an era when the X-rays were not there. So there was a lot of overlap in this term. But classically, if they speak colles, they should mean it's an osteoporotic deficient skeleton. Complaints of backache, one of the commonest symptoms of osteoporosis. Which of the following statement is false? Now they have given treatment options. Vitamin D3 can be given with calcium. We all know it is given. Calcium requirement is 1200 milligram per day. It's okay. Bisphosphonates are not given for more than 1 year. This statement is false because bisphosphonates can be easily given up to 3 years. Also remember, oral bisphosphonates can be given for a longer period as compared to IV. Also remember why this period of 3 to 5 years is usually an upper limit. Now they are trying to extend the role. This upper limit is there because they say that prolonged bisphosphonate therapy increases the incidence of the proximal femoral fractures. And this is a question that came in 2012 in AIMS. They asked you, a patient of osteoporosis on bisphosphonates complains of hip pain, what will you do? I'll get an X-ray done. I will not repeat a DEXA scan because it's a proven osteoporosis. I will do an X-ray to look at the fracture. And if they give you the next step, X-ray is normal, what next? MRI. Because it's going to be early marrow edema that will be picked up rather than doing an X-ray. And the last one, teriparatide should be given before supplementing bisphosphonates one at a time. Now this concomitant therapy is being a talk of the town. Combining bisphosphonate denosumab, PTH and bisphosphonates, or with calcitonin. But what they usually say is, do not give them together because the zoledronic acids and the bisphosphonates, and on the other hand PTH, if they are given together, they hamper action of each other by interfering the receptors. So if they have to be given, they should be given sequential. So this answer with guarded prognosis is plus minus, but obviously second answer is absolutely correct. In every exam you will find a question where two options will be somehow confusing, but in this second option is absolutely wrong. You can give bisphosphonates for more than 1 year. So we assume that the first is correct, right? Fifth question, white skeleton, immature skeleton is scurvy. Wide skeleton is rickets. So they have shown you a normal bone density X-ray, but at the end of a bone, you see there is white line of Frankel and sclerosis of the epiphysis, which is called as the Wimberger ring sign. So there are different signs which are described in with respect to the ring. The three ring signs that one must remember is the ring sign, which you see in scapholunate dissociations, the O ring sign, which you see in chondromas, and the Wimberger ring sign, which you will see in cases of scurvy. And in fact, this Wimberger ring sign is a classical, one of the diagnostic radiological features of scurvy, which is vitamin C deficiency. Patient had a fall, started with pain around the hip, shortening, flexion, adduction, internal rotation. So if they mention FADER, flexion, adduction, internal rotation in the lower limb, along with shortening, your answer is going to be posterior dislocation. If they mention classically flexion, abduction, external along with lengthening, your answer is going to be anterior dislocation. I will not like to go on other aspects of anterior dislocation because there's 1 in a million chance they'll talk about it. So one of the only causes where you know about true lengthening of a lower limb is an anterior dislocation, and FADER, that is posterior dislocation of the hip, is the commonest dislocation in the hip joint. overall commonest in the body, shoulder, which goes anterior, hip goes posterior, remember that. The other options of intertroch and fracture neck femur usually will have shortening and extenuation. They will not have this classical presentation. Nerves, if I have to read one chapter, I will read nerve injuries. And I will mark my answers according to sensory distributions. The nerves which I will like to remember, the three nerves that go in the hand, I'll remember it like this. The tip of little finger is autonomous zone of ulnar nerve. The middle finger is the autonomous zone of median nerve. The dorsum of the first web space belongs to the radial nerve. Radial, medial, ulnar. Then there are two nerves which are coming around the shoulder. The axillary nerve supplies the regimental badge area up and is the commonest nerve involved in shoulder dislocations, either anterior or inferior dislocation. The second common nerve involved in a shoulder dislocation, although rare, or around the shoulder injuries is musculocutaneous nerve. And musculocutaneous nerve supplies the lateral aspect of the forearm. So, these are the things that you must remember for the distribution, sensory distribution of nerves. Two nerves which somehow examiners love, anterior interosseous nerve and posterior interosseous nerve. The anterior interosseous nerve, they love it because it supplies three muscles: pronator quadratus, flexor pollicis longus, FDP lateral half. Anything in entrance exam, any structure that is supplied by three things or has three origins or three things is an MCQ, because examiner will only put one choice and place it to you. So these are the three things that you should remember. And if you do this classical sign where you are using flexor pollicis longus and FDP, this is called as Kilo-Nevin sign, or OK sign is for anterior interosseous nerve. The posterior interosseous nerve, which is very close to the head of radius, is principally a motor branch and will lead to finger drop. So there will be finger drop. So if I look at classical presentation, around the shoulder axillary nerve, deltoid gone, there will be regimental badge area sensory loss. Musculocutaneous nerve again supplies three muscles: biceps brachii, the chief supinator of forearm; brachialis, the principal flexor of elbow; and coracobrachialis. So these three you must remember. And just remember, biceps is not the main flexor, it's a supinator. And supinator is not the main supinator. And the main flexor is brachialis. Remember this. And when you come around the lower part of arm, right, and around the elbow, so in the supracondylar fracture humerus, you remember the mnemonic AMRU. The order of nerve involvement: anterior interosseous, median, then radial, then ulnar. Behind the medial epicondyle, remember the ulnar nerve. Around the head of radius, posterior interosseous nerve. And around the wrist, if anything happens, like a lunate or a pegulate injury, the median nerve. And then the classical test of all the nerves. Radial nerve is the most common nerve damage in the human body. Most of the common things have good prognosis. It has the best prognosis. It usually has no test. Presentation is classical wrist drop. Radial nerve palsy will have a wrist drop, which includes a finger drop with sensory loss. The other two nerves, they will ask you the test: the ulnar nerve and the median nerve. In the ulnar nerve, what are the important things you should remember? The ulnar nerve, if you give a card to a patient and ask him to hold it between the fingers, this is palmar interossei adduct, PAD. If you pull this card and the patient is able to hold it, it means his palmar and trochlea are functioning well. The second, if you ask a patient to place his hand on the table and you ask him to move the middle finger on both the sides, this is abduction, because the movement of the middle finger to either side is called as abduction because it does not have palmar and trochlea attached to it. This is called as Igawa test. Igawa with an I, not E. Correct the spelling in one of the common books. If you ask the patient, right, to hold a book between the thumb and the palm this way, you are utilizing adductor pollicis, the muscle of the thenar eminence, which is purely supplied by the ulnar nerve. This is called as a book test. And if your adductor pollicis is not functioning, you won't let the book go away. You will flex your thumb and hold the book. This is called as a Froment sign. And many people confuse this with median nerve. So remember the mnemonic FU. FU is one of the common ways every youngster knows what is FU. Every doctor knows what's an FU. FU means follow up. You must not have thought what you're thinking. So FU, Froment sign ulnar nerve, is the number one sign asked in entrance exam. And abducted little jet is called as Wartenberg sign. When you compare it with the test for the median nerve, in median nerve you have classical pointing index. You ask the patient to make a fist. If his median nerve is paralyzed, his fingers will stand out. And remember, the index finger will stand out completely, but the middle finger is partially flexed. Why? Because the middle finger tendons are connected to a ring and little finger tendons, and these are supplied by the ulnar nerve. So when they flex, if you do it slowly, you can never flex ring and little finger independent. So if you try to flex them, there will be a slight movement of the middle finger always, and the connections will decide the movement. Rule of thumb, right? How much you will move depends upon the connections you have with the neighbors. So that's how it goes. So it stands out like this. It's not this, it's neither this. So it's going to be this. This is Froment sign. When a pope speaks to a lot of people, that's how he talks. This is also called as a benediction attitude or the pope sign. Or you can also clasp your hands and put it like this. And when you're doing it, you're making a fist, these two fingers can again stand out, called as the Ochsner clasp sign. This is again for the median nerve. You can place the pen over the palm and ask the person to touch it. This is abductor pollicis brevis, supplied by the median nerve, called as a pen test. Remember, abductor pollicis longus belongs to the first extensor compartment of the wrist. So it's going to be supplied by the radial nerve. Which disease is abductor pollicis longus involved? Decurvent stenosynovitis. So if I look at this, this is a pen test, right? And these are the tests which you should always remember. And the last one, right? The median nerve is opposition. And if the median nerve is gone, the thumb is in the plane of the palm. This is called as ape thumb deformity, right? Remember, people confuse ape thumb with radial nerve. Don't do that. Remember my name, AM. Apurv Mehra, ape thumb, median nerve. मैं बंदरों ऐसे काम करवाता हूँ, right? So AM, ape thumb, median nerve. It's not for radial. I also told you, radial nerve, no test. All right. So in this picture, you can classically see that this is a pen test being done for the median nerve. And question number 8, the last question, a patient has humerus fracture, difficulty in flexion and supination. He has complaints of loss of sensation on lateral side. So the answer is going to be musculocutaneous. So this is what was Neet 2021. I hope you got 7 out of 8 correct. And if you got the last one correct, you will be in top 100. Wishing you all the best. Signing off, this is Dr. Apurv Mehra.